So I'll be brave if you're brave. I'll be brave, but only if you're brave.
Good evening, everyone. Welcome to those of you who are able to join us today during our Lung Cancer Living Room. For those of you who don't know me, I'm Danielle Hicks. I'm Chief Patient Officer here at GoTo for Lung Cancer. Tonight, for those of you who were aware, we'll be discussing stigma and empathetic communication. The objectives really are pretty simple. We hope that you walk away understanding what stigma is and what it looks like, the causes of stigma, the effects of stigma, and solutions for combating stigma, as well as a discussion around research that's happening. And stigma is such an important topic that there is literally research being done in the area to see how we may be able to overcome it. So with that being said, tonight's speakers are Smita Banerjee, PhD from Memorial Sloan Kettering Cancer Center, and Jamie Ostroff, who's also a PhD from Memorial Sloan Kettering Cancer Center. And not new to this programming is Andrew Ciupek, who's a PhD at GoTo for lung cancer. Not only is he a panelist tonight and my colleague, but he is going to help me co-moderate this conversation, which is also near and dear to his heart. So thank you all for joining us tonight.
So I thought it would be great, hearing, we talked a lot about the word kind of like stigma, but I thought it would be great with just two of you, Jamie and Smita, to just kind of start off, what do we mean by stigma, and what does kind of stigma look like in the real world? What are we talking about when we say stigma?
I feel like most people on this call can they know it when they see it or they know it when they hear it. But I will say that as researchers, we think of stigma as a thought, a behavior, or a feeling associated with a negative evaluation relevant to lung cancer. So that's the sort of textbook definition. But through our research, we've come to see that stigma is a feeling state, often described as guilt, regret, blame, shame, negative emotions for sure. We also know that part of stigma is a perception that others, family, friends, and even healthcare providers are looking down upon an individual affected by lung cancer. And then the third component of stigma, which is so important, is what we think of as constrained disclosure. And, I know that's a little bit of a wonky term. What I mean by that is it's the sense that people don't want to share their diagnosis because they don't want to hear that ubiquitous question, do you smoke? Did you smoke? I didn't know you smoke. So frankly, it's adaptive for some not to even share their diagnosis. So those are the three, if you will, subcomponents of stigma.
Yeah, I think that makes a lot of sense, and it's interesting, some of the things you're mentioning, kind of those feelings and, not wanting to share information. It sounds like that could have a lot of impact, on not just how you feel, but also kind of how you're dealing with your lung cancer, and maybe even how, you affect your care. What impacts can such stigma have, on a patient and the care they're receiving?
Yeah, I couldn't agree more that the consequences of stigma are far-reaching. And so one of the reasons why it's become so important for us, not just to study, but frankly to do something about it through our research, is because there's been studies that have shown that stigma is associated with feelings of depression, feelings of delay in help seeking, misreporting of smoking behavior, avoidance of social support. And so it's not just a thing that we can point to and say, but we think that the importance of studying and preventing and mitigating stigma is because we think that this is like a mechanism to improve both the quality of life and quality of care of patients. And I think that that's why we think it's it's sort of a precision psychosocial support, if you will, to really understand and address stigma.
Thank you for all of that, and I couldn't agree more. I think when I think about stigma and I think about the folks that I've talked to, I think quite often it may not be intended when those sort of statements come across at, like I didn't know you smoked or any of the other things, Jamie, that you touched on. But I also think one of the greatest harms is it sets this sort of false sense of security for the never smoker or the non-smoker, right? To think, well, as long as I didn't smoke, lung cancer is not something I ever have to worry about. Or if I quit smoking 20 years ago, lung cancer is not something I have to worry about. And then second to that, you touched on this sort of shame blame. And I know in speaking with folks who technically qualify based on today's criteria for screening, they don't want to go in and get screened because they don't want the finger sort of to be shaken at them saying, well, you have to quit smoking and you have to do this and you have to, they just don't want it. There's such a fear around being judged and or sort of placed in this box that it's not only delays in treatment, upon diagnosis, but really in that screening space too, where there's such a huge opportunity to capture lung cancers at an earlier stage. And then I'm curious too, from both of you, whoever would like to take it first, around the other sort of effect, and we had a conversation about this recently around this sort of implicit bias coming from healthcare providers in general that may not even know that they're doing it. So those sort of three things, I don't know if either of you want to kind of touch on them a little bit.
Let me take that question and give a little bit of my thoughts. So we did some work with lung cancer survivors, and you talked about this unintended consequence of certain conversations. And so what we've learned through the years is that words matter. How you say, what you say, all of those can have implications. Hearing from patients and survivors, one of the things that they pointed out was every time we go into the hospital or any clinic or meeting any healthcare provider, we get asked the question, did you smoke? Do you smoke? And so it is there in the charts. This repeated probes about smoking can exacerbate feelings of kind of being judged or blamed because it's in my charts. Why are you asking me over and over again? So we heard from survivors that question in itself seems to be very loaded, where people just don't want to talk about it. I'm here to talk about treatment. Can we just put smoking aside for a bit? And so the solution is very simple. The solution is provide a rationale. Why are you asking these questions when it is there in your chart? This patient came 2 days back, 3 days back, and had answered the same question. And so when we worked with survivors, we took down, what were some of these unintended conversations, and then what can we do about these? So these repeated probes about smoking was one. And then again, questions that seem to be loaded, or blaming statements. And some of the things that we heard, we would think, who will say those kind of things? But there have been experiences when patients have been told, I will not do the surgery on you if you continue smoking. Or didn't you know better? You smoked for 40 years, didn't you know better? So some of these kind of comments that come from clinicians, right now I'm really focused on clinicians, not talking so much about what friends and family say, but particularly from healthcare professionals, when these kind of questions come, it can leave the patient feeling very lost, very alone, and not knowing how to respond.
I feel like I want to at this point say that this is not an either or. We, as trained healthcare providers, should be able to take thoughtful, compassionate smoking history, advise patients struggling with tobacco dependence, and support them in efforts to quit, as well as provide inclusive, equitable care to patients. And so, I feel like I want to make sure that I punctuate at this point that anyone with lungs, I feel like I'm co-opting the go-to, anyone with lungs can get lung cancer. And we know that. We do also know that smoking remains the leading preventable cause of lung cancer, and that it's never too late to quit. So, I guess from my vantage point, the answer is not to not discuss smoking, because it actually does affect the care we provide, but to know that it's a sensitive conversation, to know that there's an addiction and people struggling with tobacco dependence do not need or want to be scolded. They want best practices support. And it's my firm belief that we can provide caring, compassionate treatment to patients, including delivery of tobacco cessation support for those individuals who need it.
That's really helpful, Jamie. Thank you. So it's, just to kind of wrap a bow on that, it's not an either or, it's more of an and also. Like, we can do both of these things. And then the last question before I turn it back over to Andrew that just sort of popped in my head. We know we see this type of stigma all around us in the lung cancer community, right? Is it similar in the heart disease community? Because we know, and please correct me on these statistics if they've changed or if I'm wrong, that and smoking's bad for a lot of reasons, right? But I think lung cancer gets singled out, which is where I'm sort of trying to get to this, right?
Yeah.
20% of all smokers will ultimately wind up with lung cancer, but roughly 80% will wind up with some sort of heart disease. Yet I don't feel, and I know a lot of people who have suffered from heart disease over the years that don't feel that same sort of twinge around stigma. Has there been any research to look at whether or not, and maybe I'm wrong, maybe there is just as much in heart disease, but if there isn't, do you have thoughts on why not?
I think one of the successful, if you will, cancer epidemiologic observations that we've noticed is that we've done over the last 50 years. We've had a really robust tobacco control public health campaign. And, there's probably not a person or a school child walking around who doesn't associate the hazards of tobacco use with lung cancer. And, there's a good side of that. But the unintended consequence is that I agree with you that, gosh, there are dozens of chronic medical conditions associated with tobacco use, but lung cancer is usually at the front of the line. And, I think you make a good observation. To broaden this conversation just a little bit, though, is that I think that there are other chronic diseases where we also know that the tendency is to blame the individual. So if you have heart disease and you have struggled with weight, or you're sedentary, or I think there are a lot of illnesses. I remember in my career early on, HIV was sort of the classic of an illness-related stigma, where we began thinking that this was a disease that was caused by sexual behavior or IV drug use, and I think we learned a lot from persons living with AIDS, HIV and AIDS, about how words matter and how we want to build an inclusive and hopeful dialogue.
Yeah, I love that. I think there was and I agree with you around the HIV/AIDS epidemic. Back in the early '80s, I remember most people feeling very safe if they were outside of what they thought at the time was a risk.
Right.
Yeah, for developing the disease. And I love how the community, the HIV and AIDS community, really banded together, which is, again, it's a really long way of me saying, which is why I'm glad we're doing this tonight, right? Because this is all about us banding this community together around this cause and kind of saying no more, right? Because at the end of the day, these are people. And to your earlier point, addiction is a very real thing. It's a very real struggle. So how can we sort of do both? And I'm going to stop there and I'm going to hand it back to Andrew because I could, as you can probably tell, I get very passionate about this and I could just talk and talk and talk and talk.
It's such a great conversation we're having. One of the things I was interested in is you just, both of you mentioned, how we're now able to do research on this and we've learned a lot of different things. And so I was just kind of, thinking out loud, delving into a little bit of what we know about stigma from the research. Are there kind of different forms of stigma, and do all patients that have lung cancer experience stigma in the same way, or are there certain types of patients that are more likely to be stigmatized against? What do we know from the research?
That's a huge question, to talk about how different people face stigma. I think what Jamie explained earlier really describes how stigma is experienced by individuals, talking about, I'm perceiving that others are judging me. So that is, the perceived stigma, internalized stigma, where I feel guilty, judged, blamed. I have all these negative feelings because of the behavior, and constrained disclosure when I don't want to talk about it. Now, what we've also seen, interestingly, is the way stigma manifests in individuals. It can differ based on if an individual never smoked, formerly smoked, or currently smoked. And so it's very interesting to see how the association of smoking with different ways in which people experience stigma.
Yeah, what I'll just add to that is, we think that another culprit in the stigma story is the historic nihilism and poor prognosis of the disease. And, I think some of the uptake and rollout, it's been hard to change the narrative about lung cancer and the incredible advances in treatment and early detection. And what's underneath that nihilism, of course, is fear. So I would say that in addition to smoking history driving the stigma observation, is that I think we as a community have a lot of work to do still about promoting the discoveries and advances that have reduced the suffering of lung cancer, improved the prognosis of lung cancer. And I think that's also a part of our anti-stigma campaign, if you will.
I actually think it was in a living room. It might have been a few years back, in talking with the patient about a certain subset, the never smoker population of of people living with lung cancer, tend to self-identify as I have never smoking lung cancer, right? And in some level, and in having deeper conversations with these people who kind of fall into that category, it makes them feel better because of the stigma. The stigma has been, they have felt it strong enough that they feel like they're somehow skirting around stigma by self-identifying. But one patient said, who was also a never smoker, said, what we don't even realize we're doing and what is unintended is that we're further stigmatizing by somehow saying we're never smoking, we've been diagnosed with never smoking lung cancer, somehow we don't deserve it. But boy, these other people, we totally get why they would have gotten it. So I just kind of wanted to point that out as I think something very real and in a conversation that is happening within the never smoking lung cancer community itself.
I can't resist sort of jumping on that one. So two thoughts. One is a historical reference. Again, when I started my career was, back in the 80s in the HIV, and there was a subgroup of patients, usually young men with hemophilia and their mothers. And I get it. It was protective. I know that it wasn't, it wasn't malicious. I don't think there was sort of an intent to throw anybody under the proverbial bus, but
Yeah.
this language about subgrouping and dividing a community, we've seen that before. Again, taking a page from the GoTo Foundation, no one deserves lung cancer. And I really have seen the patient advocacy community develop, just as I, as a tobacco researcher, have developed a greater appreciation that how we do a smoking history and how we advise patients to quit requires a much more nuanced conversation. I've really come to see within the patient advocacy community an appreciation about this unintended consequence of declaring that that a person never smoked. And I think it's made I think it's really contributing to a more cohesive community of patients, families, clinicians, and scholars when we realize that anyone with lungs can get lung cancer, and we all have a lot of work to do together to make sure that all the discoveries and advances get disseminated to the broadest community possible.
Agreed.
Yeah, I'm just so happy that you brought that up, Jamie, because that's something I really resonate with is kind of, the importance of spreading that message of hope. And, since I've been, with the organization for a few years, even just the short time, 6 or 7 years I've been working, I've seen so many new treatments get approved and so many great advances. And really, I feel like there's so many more treatments available now across the spectrum. And yet, that thing you mentioned earlier, denialism, every once in a while I still do have a conversation with a patient, and, whether they're intending it, whether it's really overt from the provider or not, you get this message of, well, I have this, one treatment available, but then, after that, I don't know, or, it's, this very wanting to approach it from, kind of, this is a really, bad thing. We don't have anything left to treat it. And I think, spreading the message of, that's not true. Lung cancer treatment has improved all the time. There's so many clinical trials going on, and kind of busting the stigma with that kind of message of hope is I'm so glad you mentioned that. It's kind of a way to, combat stigma. And I just, it's something that I encounter a lot, because it really is, a lot of reasons to not think that.
Just agreeing with what Andrew just said, we heard from patients and survivors that when I was diagnosed with lung cancer, the first message was of doom, that nothing can be done. It's too late now. This is stage 4. And so hope was almost kind of taken away, and which doesn't happen to a lot of other patients that are diagnosed with other kinds of cancers. And so hope is provided. There's so much more we can do. But what we hear from some lung cancer patients is that hope is taken away by healthcare providers. And so we have to be kind of extra cognizant and extra careful to choose our words wisely and continue instilling hope.
I couldn't agree more. And obviously, you see this big sign behind me. I don't know which way I need to turn it.
Oh, yes.
Yeah. And this is the room where pre-COVID we would hold meetings live. So the speaker panel would be up here, and you'd have not only an online group full of people, but also a room full of people. And I think hope is one of the most important things with any cancer diagnosis. But to your point, Smita, with a diagnosis of lung cancer, particularly late stage, and particularly with Dr. Google on board, it's a sort of this blessing and this curse, right? It generates a lot of fear and a lot of lack of hope. But you touched on the healthcare provider sort of space where there is sort of that. I mean, we continue to hear all the time, patients saying, well, I talked to Dr. X, and they said, regardless of where they may be or what type of lung cancer they're diagnosed with, that they maybe have 6 months to live. And it's so disheartening to me because there's not a healthcare provider out there that can put a timestamp on someone's life, right? We know based on data and based on the evidence and based on the diagnosis that there is a median, but we don't know where this person is going to fall on either side of that. And so I think that's one of those things that's still really disheartening to me when I talk to patients. They're kind of like, well, what does it matter? I'm just going to get my affairs in order and, take a trip to, wherever, because I'm not going to be here in 6 months anyway. And I worry about that less, particularly in large academic centers where the two of you are. But when I think about these more rural community settings, how can we help them? And by them, I mean the community in general. The trickle-down effect of getting this information, what's happening right now today in lung cancer, down into these communities where they don't have the benefit of focusing on any one particular type of cancer, be it solid tumor or blood, in their general oncology center, right? What they think they knew because it said so yesterday might not be true next week. So outside of your academic centers, what can we do as a community to sort of take that top down but also bottom up sort of approach to educating people, not only on stigma, but to your earlier point, Jamie, and where we've kind of taken this on all of the wonderful things that have happened in lung cancer, particularly in the last decade?
It's a really good and challenging question. I guess the first thought I have is it's forums like this that remove barriers for information dissemination. And then I have a profound appreciation for the importance of patient advocates and patient advocate organizations. I feel as though I'm not giving physicians and other healthcare providers a pass on this. I do think that we all have an obligation, no matter our subspecialty, to stay informed and be aware of current best practices. But again, you mentioned sort of Dr. Google and groups like the GoTo Foundation, where you can reach out to buddies and you can reach out to a support network. And I just think if I were to give one message, seek out informed support, and particularly trusted sources such as patient advocates who, have made their mission to get the word out. And so those are two thoughts I have.
I agree with what you're saying, Jamie. I think there's been so much more connecting across the community to share things. Certainly the role patient advocacy organizations play, but also in patients. One of the things I've seen is that a lot more now with the power of social media and the internet and other things, patients have been connecting to each other in ways that we've not seen in the past. And I think it's so powerful just hearing that message of hope, from someone else who's been through this, experience like you. And I think, all those connections among the community are really, helping in this area. And so it really kind of resonates, can we get more, to break down these barriers and really, not feel so isolated is such a big part of it.
Yeah. And I'd say, to follow up on that, I think, one of the silver linings of COVID is, like we're doing tonight, that we have virtual conversations across the country. And I think I want, to sort of acknowledge that this happens in the health professional community. It happens in the patient community. It happens in the caregiver community. And, I think that we'll look back on this period of time and see that we broke down some barriers on information sharing as a result of all sort of trying to become more facile with virtual forums of communication like this and others.
I agree. And to adding on to what Jamie is saying, I think, we cannot understate, how important it is the work that patient advocates are doing. But on the flip side, it's also very important to continue to provide information, education, simple resources to healthcare providers. They are a busy lot. So, I am not taking that away and saying that, we have all the tools and we are going to educate them, but they are a busy lot. And so giving them resources that are easy to implement in their busy clinics, I think can be very helpful. And then forums like this that can bring not just patients and advocates together, but also health providers. so that they are able to hear the other side of the story and see how words matter and what impact some of the unintended words can have on patients and caregivers. So I think bringing the groups together as well as continuing to provide resources to healthcare providers is also very important. And I'll just share one very small experience. So when Jamie and I started our work 7-8 years back, we thought we are going to train the doctors, the oncologists, and this problem will be mitigated. And so when we started the work and when we heard stories from lung cancer patients and survivors, what we heard was, don't just train the doctors, it's the nurses, it's the nurse practitioners, it's the fellows, the social workers, everybody who's involved in the care, everybody needs to be trained. So you cannot point fingers at one and say, the problem lies there. It's the whole system that needs to be trained on providing empathy, on providing compassion, and teaching them the importance of kind of the words that they use and the impact that the words have on.
I could not agree with you more. And I think that, as go-to, we would love to be in every healthcare facility from, top to bottom and coast to coast and globally, really providing those tools, Smita, to your point, and that access to information. But I also think one of the things we do that is important is empowering the patient, right? Because I know quite often, and Jamie, you said this a little bit ago, people need to find resources, trusted resources, and quite often, more often than not, patients just inherently trust their physicians, right? Their doctors and their healthcare teams went to school for this, for them. And I think they need to not be afraid to empower themselves to get access to the information, whether it's from GoTo or there's obviously other resources out there, to empower themselves on their disease so that they can go back and have this informed conversation with their healthcare providers. And I've had patients say to me, oh, no, I would never want to question my doctor. And giving your physicians access to information is not questioning them, right? It's just saying, hey, I heard about this. What do you think? And I've also heard patients say, well, Danielle, why did I have to come to you to get the information to bring it to my doctor instead of, them bringing it to me? And to your point, Smita, it's a tough job right now. Long gone are the days of physician desk references where you just kind of opened it up and thumbed through and you're like, here, this is what we do, right? Precision and personalized medicine is continuing to expand so rapidly. And doctors are humans, right? They don't have computers for brains. So anyway, my sort of drive home point is for patients, and maybe not just the patients, definitely not just the patients, but the caregivers and families and loved ones of the patients to empower themselves so that they can have these educated conversations with their.
Andrew, I wonder whether or not it would be worthwhile for Smita to just summarize some of the research we're doing about empathic communication skills, if this is a good time for that.
Yeah, I actually think that'd be a fantastic one because I feel like we've talked a lot about what stigma is and the impacts, and now I'm kind of interested, in what the research like yours and others say, about what we can do to prevent and reduce lung cancer. So, what can you kind of share about your work and what's being done, out there to help, deal with this problem?
Looking at solutions, what can we do to reduce lung cancer stigma? I'm sure there are other approaches, but one very simple and something that we hear, in research and what we've read a lot is empathy, empathic communication, and that goes a long way. And when we are talking about empathy, we are really talking about conversations that are compassionate. When you're trying to understand why is my patient reacting the way they are reacting, what may be happening with them, and as a clinician to know how to react when I feel empathic towards someone. What can I say? What can I do so that my words don't feel flat, so that my words don't appear fake? And so the training that we have developed, it's an empathic communication skills training to reduce lung cancer stigma. And what we are doing is we will be working across 16 different cancer centers in the United States, working with 160 clinicians, 960 patients, to really look at what happens when clinicians participate in a training of this sort, and does that change the way they communicate with patients and their family members? So that is the work that we are doing in the US. Jamie and I just returned from a week-long trip to Nigeria, where we took this training and we adapted it for the patient population in Nigeria, and to see, can we teach clinicians there, and will it work, and how does stigma look there, what is the face of stigma there. And again, some very interesting work that we are doing globally, because stigma exists. These feelings of blame, feelings of regret, guilt, they're universal. Not just focused in the US, but we also saw that in Nigeria, patients feel guilty. They feel bad for putting their families through this. They feel guilty that maybe if they had changed their behavior, things would have been different. So things are very similar. And so really kind of conducting this empathic communication skills training providers of using simple tools that they can use in their communication with patients to reduce patients' experience of stigma, is the work that we are currently doing.
One thing I just want to add to that is that, this is sort of putting on our science hat, is that what Smita is describing is actually a large randomized clinical trial where we're not just proposing an enhanced way of communicating, but we're testing it against usual care. We know that clinicians are busy, and we want to make sure, we've done pilot work and we've seen that it has promising results in a single center. But our ultimate hope is that when we're done with this trial, we'll have an optimized toolkit for healthcare providers treating patients with lung cancer. And then we'll work with partners like the GoTo Foundation and others to widely disseminate it. But I definitely want to say that this is an area of behavioral science research where we feel that we want these interventions to be just, be just as rigorous and empirically based as other tools that we have.
Jamie, can I ask, is this study still enrolling?
We are still enrolling. Yes, we are still enrolling cancer centers. So this is a 5-year study. We are in year 2 of the study. So, we're still in the process of enrolling more centers.
Yeah, that's great. And I ask because, shortly after this airs tonight, we do a follow-up of what internally we refer to as a show notes blog. But I would love to be able to share this information with our community for any who might be interested in participating, because I think it's such important work, particularly the benefit it could have in development of these resources and toolkits that will actually have real-time impact. So we may be following up with you to get some more information.
I just think that's so great, and I love the word Jamie was using earlier about having evidence-based approaches to this, and taking a real research-minded approach, because it's so heartening to me to hear that, we're applying, just like any other problem we would approach in the realm of cancer, whether that be treatments or things, these are powerful research tools we can do to find this, and the fact that, people are working on this is just, a really great message for me to see, coming apart. And it's interesting, you mentioned training with providers, and I find it interesting, and others in the audience too. What does that look like? Like, I'm sure you could write lots of blogs about stigma, and providers could read them, but it may not, really impact them. But how do you train a provider to be more empathetic? I'm just fascinated by that concept.
It's a brief training. It's a 2-hour training, and where we spend about 30 minutes on a didactic component, where we talk about what stigma is, how does it look like, what are some of the consequences of stigma, and then we talk about what can we do about it. So that takes place for 30 minutes. We show some examples of exemplary videos of how you can communicate, use some of the communication skills to have empathic conversations. but the bulk of the training are role play scenarios where participants, so clinician participants, where they get the opportunity to work with trained actors. And in our world, we refer to them as standardized patients. So they worked with trained actors and work on challenging conversations that they have had. So we have a basic kind of a patient scenario, but then we tailor it as per each learner. So I'll give you an example. So one learner might say, you know, I find it very difficult to talk to my patients when they get irritated or annoyed as soon as questions of, prior history of smoking come up, and I just don't know how to, how to deal with that. And so, we have a patient scenario. Our actors will become angry when you talk about smoking, and we will talk to them, and we'll talk to them about different communication skills that they can use in that communication encounter to kind of calm the patient down. Someone else might say, I can deal with anger, that doesn't worry me, but it's the internal blame when the patients say, I did it to myself. I've been such a fool. Didn't I know better? And I don't know how to react to that. And so we have them play the part, and then work with some of the skills that we are recommending. So as facilitators, we provide certain suggestions, but there's also peer learning. So different clinicians in the room, they will all work on challenging scenarios for themselves. They get feedback from their peers in the room. They hear from facilitators who are facilitating this training, and they also hear from the actors who are portraying the roles of patients. How did they feel when the clinician said X? What was their response? Why did their anger go down? What did the clinician say or do that made them kind of reduce feeling irritated or angry? And so there's a lot of feedback that we build into these role play sessions. But I have to say the bulk of the training is really to practice saying what we are talking about. Because we can hear a lot of things, but after some time, I think we stop learning until we do it ourselves. And so this practice is kind of really, really helpful.
That's so great, and it's great to hear there's work focusing on that too, because I know we all want, when we see a doctor, to see someone who has the knowledge to treat us. But I hear from patients all the time, how important it is. You want also someone in your corner and someone who kind of, you feel like you're supported and is able to connect with you. And so it's great that they're, from your research, doctors are trying to actively learn how to do that better. It's not just about learning treatment. How can we connect with our patients, and have this and do that better as well. And so I'm really pleased to hear that. And I think it's really interesting just, delving in. Do you talk about, obviously this tells us about, how to be more empathetic, train people to see, how can we be in someone else's situation and look there. Is there anything you've learned? I think it'd be kind of a nice kind of, for all of us here, we may not be doctors, we may be, caregivers or friends or patients who are experiencing stigma. Is there anything from research or just your experience that we can do as a community, either as a lung cancer patient who experiences stigma, to do in that situation, or someone who wants to be a friend or supportive to someone with lung cancer, how can we better, help reduce that stigma?
I'll talk about some very simple skills, and again, there are more, but there are some very key empathic skills that really can be used to have a compassionate conversation with patients. Being able to acknowledge someone's emotions. You look so stressed out. What's going on? In this little phrase, you not only made recognition of someone, the third person's emotion that you're seeing, but you also encourage them to express themselves. And so, being able to acknowledge emotions, being able to validate it, or tell the patient it's okay to be experiencing what you're experiencing. This is so hard. I can't even imagine what you must be going through right now. Phrases like these, words like this, when you're validating someone's emotions or experiences, almost signaling agreement with what the patient is saying, that goes a long way. As clinicians, normalizing emotions, telling patients they're not alone. A lot of other patients also go through these anxieties, these fears, etc., telling the patient, we've seen this, and we know how to work with this, again, can be very helpful for the patient. And so there are, I can go on and talk about different communication skills, but some of these empathic skills really allow you to connect with the person, and leave an impact.
I started by saying that the most common question that patients are asked when they disclose their diagnosis of lung cancer is some variant of, did you smoke, or something like that. And I'd love to see the first question that to replace that with, how can I help? How can I support you through your illness and treatment? Because frankly, that's what all individuals with cancer and other illnesses want, right? So I'd love to see that the first question we ask patients with lung cancer and all cancers is just simply, how can I help?
Yeah, like you said, just telling people you're not alone. I mean, we're here as a community right now, everyone going together, and it can feel, we know how isolating, cancer diagnosis can feel sometimes, but just, really conveying that message. I like that, you're not alone. There are others out there. We've worked with them. There are things we can do, and just being that supportive is so great.
From your perspective, what's the one thing you hope that anyone watching this programming will take home?
Smita said this earlier, and I would say, words matter. And the words matter as clinicians, as family, as friends, as coworkers. That greater awareness of conversations and word choices. Even now, the ISLAC has a language guide where they're advocating what we call person-first language. So I think what I'm saying is words matter. And to the extent that we come together and we listen to each other about the kinds of dialogue around lung cancer that we find helpful, inclusive, the community will be in a better place because of that. And we as clinicians will be better able to support our patients.
The other thing that I've learned from Jamie is, if you have lungs, you can get lung cancer. I think that particular phrase, I find that very helpful. So it just takes away the blame, judgment, guilt, and really puts it, if you have this, you can get cancer. And so walking away with this really allows any individual to seek help without feeling judged or without getting blamed. And I think that is very important.
Yeah, it's just so true. I mean, both of what Jamie and Smita said, I just totally agree with. I think the take home for me is that, at the center of everything, there's a human being, and, that's who we're talking about. And, all these things that we're saying, anybody with lungs can get lung cancer, everyone needs support and things, is just all encapsulated in that. And that, when someone's diagnosed with cancer, it's going through an experience that, as a human being, the rest of us need to say, I want to support that person because they're worthy of support. And it's so hopeful for me to hear that there are people, like you and other researchers who are approaching this in a systemic way and trying to make sure that, all the patients get that hopeful message, get that support they need, and, that every day we make progress toward that. And that's why, this has been such a great conversation for me. It's given me hope to hear that there's work in this area and that we are making strides. So.
Yeah, I could not agree more. And I think, Jamie, when you said words matter, it made me think, words don't just matter in this instance, right? They matter on the playground in grade school. They matter in your home life. They matter in your professional life. So, it's just the words matter thing. Trust me, I'm going to take it and I'm going to use it in all aspects of my life because it couldn't be more true. So with that, I want to say a huge heartfelt thank you from myself, from Andrew, from the rest of my colleagues and the entire GoTo staff, as well as our lung cancer community, to the both of you, all three of you, for coming on and I'm going to say starting the conversation with our community about stigma and empathy and empathetic communication. It means the world to me and to them, I am sure. And of course, all of our supporters, Amgen, AstraZeneca, Boehringer Ingelheim, Bristol Myers Squibb, Daiichi Sankyo, Eisai, Foundation Medicine, Genentech, Janssen Oncology, Merck, Mirati, Novartis, Regeneron, Sanofi, and Takeda. Thank you so much for continuing to believe in this programming and enabling us to get it out there every month. to everyone. So until next time, everyone, please enjoy your evening, and we'll see you soon.
So I'll be brave if you're brave. I'll be brave, but only